Hi everyone, this is Dacia. We're going to go over your Med Administration PowerPoint. It includes documentation and reporting and all the information you'll need for your exam coming up and also for your skills checkoffs. I recommend that you do read these and look at the chapters in your book, Chapter 23 and Chapter 17, so that you know exactly what's going on for your exams. What you're looking at here is a drug label. You'll see these on your exams, and you should be able to get all your information from the drug label for helping you to determine what medication you're going to give to your patient, what dose. Do I do 1 tab or 2 tabs or things like that when you got to do a little conversion possibly when you're at the bedside. If you follow these down, here's your dosage. That's 333 milligrams. Your generic name is erythromycin. This is your brand name area tab. We know it's the brand name because it has a capital letter there and a trademark. Here's your drug form. These are more instructions on the medication, like this says dosage may be administered without regard to meals. What does the tablet look like? Do not accept this or use it if the seal is broken. Down here you have the lot number and expiration date. You would need these. You notice when people give you a flu shot maybe or any vaccines, they always put the lot number and the expiration date. That can become important if they notice a trend in a particular area, say whatever, a flu vaccine or something like that. People become detrimentally ill from it. They notice that 16 of those patients all got flu shots in the last couple of days. They're going to go look for that lot number to see if that batch was put in that particular area and a trend was identified. So drugs go by different names. So the chemical names it's the exact description of the drug's chemical composition and molecular structure. And then the generic and non-proprietary name is assigned by the United States Adopted Names Council or the USEN Council when the developing manufacturer is ready to market the drug. This is usually similar to the chemical name, but in a simpler form. The official name is also the generic name that's listed in publications such as in the United States Pharmacopoeia, the USP, and the National Formulary. And then the brand or trade name is what the drug is sold as in stores. The brand name is easily recognized, I told you, because of the capital letter and the trademark. Different manufacturers of the same medication may give it different brand names. Prescription drugs require a written prescription from a healthcare provider like a physician or advanced practice nurse who is licensed by the state to prescribe to dispense drugs. Then your non-prescription or over-the-counter drugs may be purchased without a prescription and are assumed to be safe for the general population if consumers follow the manufacturer's directions. Back in the 80s, medication was not sealed like it is now, and some foods probably weren't then either, but the drugs weren't necessarily sealed like they are. But back in the 80s, somebody was going around and replacing Tylenol with, they would take the bottle home, add arsenic to it, put it back on the shelves, and it would be sold. That person killed 12 people, or I'm sorry, 7 people. One of them was a 12-year-old little girl. So, of course, that's what changed how they packaged medication, was that disturbing thing that person did back in the 80s. So things are always changing. Your over-the-counter drugs, I remember ibuprofen becoming over-the-counter when I was a teenager, so in the form of a brand name Nuprin, which I don't think that is made anymore. But so things are always changing, and different meds end up on the counter, and there are ways that they package and do things to make everything safer. You will be seeing these drug labels on your exams. Drug listings and directories. There's no way in the world you're ever going to know absolutely everything there is to know about every single medication. So the good rule of thumb is if you're giving a medication you're not familiar with, you should be looking it up. So you're not going to know everything, but you got to know where to go to look it up so that you safely give medicine to your patients. So we talked about the pharmacopoeia and the formularies, the nursing drug handbooks. These are great. They're updated usually yearly. I like these. I always get one every year, and I refer to those a lot for drug questions. Your PDR, your physician's desk reference, pharmacology text, electronic and internet-based formularies, a clinical pharmacist, medication package inserts, institutional medication policies and procedures. You'll get familiar in whatever specialty you're working where you won't have to look up meds all the time. You'll just be familiar with those, in certain populations or on certain units. They use the same kind of meds mostly. So, if you work in the ICU, you know that a lot of people are on propofol, and you'll kind of figure that out as you get trained and everything. You won't have to get your little book out to check every time, but you should always double check your meds and know what the safe doses are and things like that. So if a doctor gives you an order that's, weird, and you're looking at it like that can't be right, you would always clarify that order with the physician. Federal, state, and local laws control drug administration, standards of nursing practice, state nurse practice acts, and organizational policies and procedures define your role and responsibilities in administering medications. You must be familiar with them to know what you can and cannot do, as well as limitations based on your own experience, skills, and knowledge. Your legal considerations: the U.S. drug legislation sets official drug standards, defines prescription drugs, regulates controlled substances, improves safety, and requires proof of efficacy. Nurse Practice Acts and Institutional Policy. The Nurse Practice Acts and Institutional Policy identify nursing responsibilities for administration and client monitoring. In most states, a nurse cannot prescribe or administer medications without an authorized provider, which would be a physician or an advanced practice nurse prescription. State boards of nursing also regulate the types and routes of medications that can be administered by various levels of nurses. In some states, LPNs can't administer IV meds, but in some states they can. And violating your scope of practice can result in disciplinary action. You want to make sure nobody, if anyone ever asks you to do something that you know is outside of your scope of practice, you would always say no. You have to protect yourself and your license. The Food and Drug Administration, or the FDA, of the U.S. Department of Health and Human Services regulates the manufacture and sale of all meds and monitors their safety and effectiveness. It also regulates through controlled clinical trials the testing of any medication that is to be marketed and sold in the United States. Generally, the agency expects that the drug maker will submit results from 2 well-designed clinical trials to be sure that the findings from the first trial are not the result of chance or bias, right? So with doing clinical trials and things, you have to be able to replicate it to prove your theory. The FDA drug approval process: the drug company must first test their own drug. So the drug company does all the testing. They verify it, that it works correctly, and that the health benefits outweigh the risks. Then evidence from these tests are sent to the FDA Center of Drug Evaluation and Research, or CDER. Then CDER's team, like doctors, scientists, pharmacologists, chemists, they review the data. If data is found to show health benefits do outweigh the risks, drug is approved for the sale. But keep in mind, the CDER and the FDA they do not test the drugs themselves. So they have to go by what the drug manufacturers data tells them. Treatments or services outside the traditional healthcare system are known as complementary and alternative medicine, or CAM, C-A-M. They include medical systems such as homeopathy, naturopathy, chiropractor, and traditional Chinese medicine, as well as specific treatments like herbal meds, dietary changes, massage therapy, yoga, aromatherapy, prayer, and hypnotism. Dietary supplements, herbal remedies, tinctures, vitamins, etc. can interact with other drugs. That's why it's always important to reconcile their med list and know what they're taking before you prescribe anything or give anything. You can't prescribe, but the doctor does. There's growing interest in CAM for various reasons, including costs of traditional care and increasing cultural diversity in the population. And one might say now people are just a little more savvy after the big COVID things that happened, that now they're looking at alternative things. So it's always important to ask what medications they're on. On this list here, you know, people use all these kinds of things, and then prayer. People that have some spirituality in their life, it's been statistically proven that sometimes they fare better during illness because whatever that higher power is that they believe in seems to help them manage through life and illness. This is the USA drug schedule chart. So you, as defined by the U.S. Controlled Substances Act. So you have Schedule 1 drugs, 2, 3, 4, 5, and then the 6 is just unscheduled, like over-the-counter availability, legal without a prescription, like alcohol, aspirin, caffeine, things like that. Controlled substances are drugs considered to have limited medical use or high potential for abuse or addiction. Under the Controlled Substances Act, the CSA of the Comprehensive Drug Abuse Prevention and Control Act of 1970, it is illegal to possess a controlled substance without a valid prescription. Controlled substances are classified by schedules. So we talked about there's a Schedule 1, and these are drugs that have a high potential for abuse and no acceptable medical use, like heroin, LSD, ecstasy, peyote, mescaline. Back in the 60s and all that, they used like LSD. They used LSD and things like ecstasy and like group therapy or marital therapy, couple therapy, because they believed it would help them drop their inhibitions to be more honest. Schedule 2 identifies drugs that have an acceptable medical use but a high potential for abuse, like opium, morphine, cocaine, oxycodone, or Oxycontin. Schedule 3 identifies medically acceptable drugs that may cause low physical but high psychological dependence, codeine, and then hydrocodone less than 15 milligrams. And then Schedule 4 identifies medically acceptable drugs that may cause mild physical or psychological dependence, like Valium, Xanax, and Halcyon. Valium back in the day, like 50 years ago, every woman seemed to be on Valium. It was like the big thing back then. Sorry about that. And then Schedule 5 identifies medically acceptable drugs with limited potential to cause dependence, like Robitussin or hydrochloride with atropine sulfate. Other things about your controlled substances: they must be stored, handled, disposed, and administered by regulations established by the DEA. Only prescribers with a national provider identification number can prescribe. Must be double locked. Facility must keep record of every dose administered. Count must be kept and performed at specified times. And unused medication must be wasted with a witness. It's always very important when you come onto your shift, mostly really in long-term care facilities that are just still using those Rolly med carts, where the outgoing shift is counting with the oncoming shift to make sure that the NARC count is right. And in the Pyxis, if you use that, or the Omnicell, things like that are computerized, you always have to count. You'll count the drug, you'll count what's in the drawer, put that number in, then you'll take what's needed for your patient. So it'd say how many are there, you're going to say 10. How many do you need for the patient? You're going to say 1. Then it's going to say how many pills are left, you're going to put in 9, and it will track that. And then obviously if there's a discrepancy, the computer will generate that discrepancy, and the pharmacy will be like, hey, your drug count's off, that needs to be checked. And then if the drug counts off, or somebody doesn't follow the rules of controlled substances and stuff like that, you can get reported and you can get in trouble for that. There are all kinds of medication systems. So you have stock supply, that's where it's bulk quantity. Stock supplies require you to measure the dose each time a patient needs it. So the potential for measurement error is present each time a dose is prepared. However, a bulk supply of medication is often very cost effective. For example, Tylenol elixir and cough syrups may be kept in large multi-dose bottles from which you measure doses for more than one patient. Your unit doses is the prescribed amount of the drug the patient receives at a single time. Each unit dose, usually one tablet, is individually packaged and labeled with the drug name, dose, and expiration date. The pharmacist checks each unit dose before sending the drug to the nursing unit, and you will recheck the drug and dose when preparing it for administration. The unit dose system not only saves nursing time, but also is the safest method because of the double check system. And then self-administration. At times while in the hospital, patients may self-administer meds. For example, they might have some sublingual nitro for chest pain, and they self-administered at home. They can also do it in the hospital. The drug prescribed for self-administration are supplied in individual containers and stored at the patient's bedside. And it's always important, that if you notice a medication bottle or something later on in your shift on a patient, you should always ask about it, because you still need to know what medications there are, and you could work it out where the patient could self-administer as long as it was a medication that was safe while they were in the hospital or wherever they're at. So that's always important too. If you happen to find, bottles in a drawer or something like that, you should question the patient about it. I mentioned the Omnicell and the Pyxis. These are just automated dispensers. An automated dispensing system is a computerized system similar to the unit dose system. The lock cart contains all the meds frequently used on a particular nursing unit. Then the computer database contains records and counts of the meds, as well as the medication prescriptions for each patient on the unit. The medications are usually packaged in unit doses, but some bulk meds may also be kept in the cart. This method allows for immediate administration of a newly prescribed medication, PRN meds, controlled substances, and emergency medications, because the nurse does not need to wait for the pharmacy to fill the prescription. So, of course, when drugs enter the body, there's all kinds of things that it goes through so it can make it to the target area in the body. So, pharmacokinetics is what happens to the drug in the body, and then pharmacodynamics, how does the drug affect the body? So, in pharmacokinetics, how the body processes a drug, it focus most of the drug and the body, refers to absorption, distribution, metabolism, and excretion of the drug. These four processes determine the intensity and duration of a drug's actions. Each drug has unique pharmacokinetic characteristics. Your pharmacodynamics looks at the complex interactions between the drug, the body, and the disease process. An example, if the patient has an infection, pharmacodynamics will look at the interactions of the antibiotic ordered, the patient's body system, and lab results, and then the pathogen that's causing the infection, primary and secondary effects of drugs. So when you think about pharmacokinetics, think about absorption, distribution, metabolism, and excretion. Absorption refers to the movement of the drug from the site of administration into the bloodstream. The rate of absorption determines when a drug becomes available to exert its action. Thus, absorption also influences metabolism and excretion. Absorption depends on the route of administration. So how are they taking the med? Orally? Are they getting it through an IV? Drug solubility, how's the drug made? Effects of pH and ionization, and blood flow to the area. Distribution is the transportation of the drug in body fluids, usually the bloodstream, to various tissues and organs of the body. Because blood goes to all parts of the body, theoretically, a drug can produce effects intended or unintended anywhere. The rate of distribution depends on the adequacy of local blood flow and to the target area, the site where the drug effects occur. It is also influenced by the permeability of capillaries to the drug's molecules, as well as the protein binding capacity of the drug. Metabolism, or aka biotransformation, is the chemical inactivation of a drug through its conversion into a more water-soluble compound or into metabolites that can be excreted from the body. Once a medication reaches its site of action, it's metabolized or changed into its inactive form in preparation for excretion. Metabolism takes place mainly in the liver, the first pass effect, but medications can be detoxified in the kidneys, blood plasma, intestinal mucosa, and lungs. Excretion. For excretion to occur, drug molecules must be removed from their sites of action and eliminated from the body. Drugs may be metabolized completely, partially, or not at all when they are excreted. The following are common organs of excretion, mostly the kidneys, that's important to remember, liver, GI tract, lungs, and exocrine glands. The renal system is the primary site of excretion, so if your patient has decreased renal function, you're going to really need to monitor for medication toxicity. So what are the factors that affect absorption and all the other routes? So route of administration, drugs are manufactured for a specific route of administration. So you have oral, sublingual, buccal, inhalant, topical, enteral, and parenteral, and are absorbed at different rates depending on the route. The form preparation of a drug usually determines its route of administration. Drug solubility, that just refers to the ability of a medication to be transformed into a liquid form that can be absorbed into the bloodstream. Enteric-coated drugs cannot be decomposed by gastric secretions. The coating thus prevents the medication from being diluted before it reaches the intestines. In this way, the coating delays the action of the medication. It also decreases irritating effects of the medication on the stomach. So like there's enteric-coated aspirin, obviously. Time release or sustained release medications are formulated to dissolve slowly, releasing small amounts of absorption over several hours. So just remember, enteric-coated drugs and time-release drugs, sometimes the drug will even say ER, which just means extended release. Those drugs cannot be crushed. Excuse me. So another factor that affects it is pH ionization. The pH, or relative acidity or alkalinity of the local environment, also affects absorption. The acid content of the stomach aids in transporting the medication across the mucous membranes, so acidic meds, like aspirin, are more readily absorbed in the stomach than basic alkaline meds, such as sodium bicarbonate, which are readily absorbed in the more alkaline small intestine. The ionized molecules are lipid insoluble and thus cannot pass easily through the phospholipid layer of cell membranes. Blood flow. Medications are absorbed rapidly in areas where blood flow to the tissue is greatest, like the oral mucous membranes. Areas that have poor vascular supply, like the skin or scarred areas, experience delayed absorption. Excuse me. Factors affecting distribution. So local blood flow. The rate of distribution depends on the adequacy of local blood flow to the target area. The target area is just where the drug's effects are going to occur. It is also influenced by the permeability of capillaries to the drug's molecules, as well as the protein binding capacity of the drug. Drug molecules must leave the blood and cross capillary membranes to reach their sites of action. Some capillary membranes act as barriers. The capillary networks in some organs consist of tightly packed endothelial cells that prevent some drugs from crossing them. Protein binding capacity. A drug's tendency to bind to plasma proteins in the blood also affects distribution. For a given amount of a drug, some molecules bind to the plasma protein, but then the other ones just roam around free. So only some will bind, then the other ones will just hang around doing their thing. For example, nearly all acetaminophen Tylenol molecules are free in the bloodstream and are therefore pharmacologically active. By contrast, only 99% of the anticoagulant warfarin, or Coumadin, is bound in the blood. Its effects are produced by only the 1% of warfarin molecules that are free. Factors affecting metabolism, liver function, that's one of them. So remember that if the liver function is impaired, like liver disease, cirrhosis, hepatitis, things like that, or just normal aging, the drug can eliminate more slowly, which means it could become toxic. They're keeping, they're ingesting their medications, but the liver still hasn't caught up to get rid of the rest of the drug. But metabolism takes place mainly in the liver, but it can be detoxified also in the kidneys, blood plasma, and intestinal mucosa and lungs. Health disease status also affect drug metabolism. The first pass effect, oral medications are absorbed from the GI tract and circulate through the liver before they reach the systemic circulation. Many oral medications can be almost completely inactivated this way. This inactivation is known as the first pass effect. For this reason, oral medications are formulated with a higher concentration of the drug than are in parenteral medications. That's interesting. The body is made that way, right? Like it comes in and the liver tries to get rid of it first. That's interesting. Excretion, elimination of the drugs. For excretion to occur, drug molecules must be removed from their sites of action and eliminated from the body. Drugs may be metabolized completely, partially, or not at all when they're excreted. The following are common organs of excretion: lungs, exocrine glands, liver, GI tract, and kidneys. This is just a table in your F.A. Davis book, chapter 23, that kind of shows you the effects of what effect, how the effects happen in children versus older adults, or across the lifespan there, how it affects absorption, distribution, metabolism, and excretion. You don't have to memorize that. It was just a little table to show you what happens across the lifespan. The client has been on a low protein diet. This will most likely affect which pharmacokinetic process? What do you guys think? So the answer is distribution. Distribution is all about how a drug or something like a low protein diet affects the transport of tissues and organs. A low protein diet may lead to an inadequate level of plasma proteins, which will affect availability of the free drug. A would be the movement of drug from the site of administration into the bloodstream. B would be the removal of the drug from the body, occurs where? Renal, hepatic, GI tract, lungs, and exocrine glands. And D would be the biotransformation of the drug into metabolites that can be excreted from the body. I would make sure that I know what the 4 of these are, basically, so that you will know those. It will be important for you to know. So let's look at some concepts related to pharmacokinetics. If you look at this little drawing here, so here's your initial dose. They have their antibiotic, right? Here's your therapeutic level range right here. So you give the med and it starts working its way up, right? So it's working its way up. The highest concentration here is the peak, and then it starts working its way down, and then of course it gets excreted. They have a half-life and all that. So time onset and peak. So the onset of action is the time needed for drug concentration to reach a high enough blood level for its effects to appear. This is the minimum effective concentration. When the concentration of medication is highest in the blood, the medication has reached its peak action. Therapeutic level is the concentration of a drug in the blood serum that produces the desired effect without toxicity. The therapeutic range of a drug is a range of therapeutic concentrations. At onset of action, serum drug level is minimum. The peak level occurs when the drug is at its highest concentration, when the rate of absorption is equal to the rate of elimination. After that, metabolic and excretory processes begin to remove the drug from the tissues and blood. The trough levels occur when the drug is at its lowest concentration right before the next dose is due. Sometimes they will draw specifically for an antibiotic called vancomycin. They give that IV a lot. I mean, there's oral doses too, but what they'll do typically is someone will be on vancomycin, and every day they'll get a peak and trough level done. So they'll get their regular dose like in the morning, and then several hours later they'll be ordered to have a peak and trough. Then sometimes a doctor will tell the pharmacy, let the pharmacy dose it. So then you would just get those lab values, the peak and trough, let the pharmacist know, and then they would determine based on that peak and trough and their formula what the next dose of the vancomycin is going to be. So you'll hear peak and trough levels for that drug in particular. The half-life, a medication's biological half-life is the amount of time it takes for half of the drug to be eliminated. So think about taking tramadol. That's a narcotic like pain reliever. It has a half-life of approximately 6 hours. This means if you take 50 milligrams at 0800 by 1400, half of that dose, or 25 milligrams, will still be left in the body, right? So in 6 hours, it took it 6 hours for half of it to get out of the body. So they had 50, right? So then 6 hours later, if half of it's gone, then that means there's still 25 milligram there, will still be left in the body. In 12 hours, 1/4 or 12.5 milligram of the initial dose will be left in your body. We know that elimination of the drug occurs in one of several places. What did we talk about? Renal, hepatic, lungs, exocrine glands, or GI tract. So if we have a disease process occurring in the organ that eliminates the drug, will have longer half-lives because excretion is impaired. And that's where you can run into toxicity, right? Concentration of active drug. The effectiveness of a medication depends ultimately on its concentration at the intended site. And just remember, a lot of drugs, as far as reactions to them, or sometimes even adverse events, sometimes can be dose related, so it just makes sense that that's why we say it's always a good rule of thumb is start low and slow, right? So other factors affecting pharmacokinetics, you have age. So infants and little kiddos, they require smaller doses because their bodies are smaller, right? So usually their doses are weight-based. Elderly typically have lower functioning kidneys and liver, which can result in the lower excretion and therefore toxicity of meds. Your body mass. Right now, medication dosages are calculated for the average weight, which is about 150 pounds. But your 450-pound berry patient may need a higher, a much larger dose so that they can get the same effect as somebody that might be smaller. Gender, hormones, body mass, and differences between fat and water distribution that affects, means that drugs do affect men and women differently. Pregnancy, drugs known to cause developmental defects in the fetus are called teratogenic drugs, and these are to be avoided during pregnancy. That would be something you may want to remember. Environment, health and cold causes changes in peripheral vascular circulation and can cause changes in absorption, especially in topical meds. And then routes of administration, local effects of a drug occur at the site of application, like topical applications of drugs to the skin, so little if any absorption occurs. Systemic effects require the drug to be absorbed into the bloodstream before it can be distributed to a distant location. A drug may enter the circulation either by injection into the vein or by absorption from other areas like the muscles, stomach lining, mucous membranes. And then the timing of administration, food and circadian rhythms can alter absorption and excretion. Fluids, insufficient fluid can interfere with absorption. If they're insufficient fluid, they could be dehydrated. Pathological states, diseases that cause circulatory, hepatic, or renal dysfunction also interfere with pharmacokinetic processes. Genetic factors, different groups respond in different ways to meds. So your book gives an example of Asian patients who may metabolize opioids at a slower rate than others. So that's why you wouldn't give a super high dose to somebody. You wouldn't anyway. I mean, it's a good rule of thumb, start low and slow. Psychological factors, anxiety may cause resistance to tranquilizing drugs. Placebo effect, if the patient thinks the medication is going to help. they will feel better even if the medication doesn't really provide any actual concrete help, or help that you can prove, I suppose. So pharmacodynamics or effects of drugs. So you have drugs, primary and therapeutic. Remember that pharmacodynamics is looking at how the medication achieve effectiveness by drug molecules interacting with target cells and the resulting biological response, and to then evaluate patient outcomes to the medication. So primary or therapeutic effects of medications are effects that are predicted, intended, and desired. The primary effects, in short, are the reason the drug was prescribed. Types of primary effects include the palliative effects. Palliative effects relieve the signs and symptoms of a disease but have no effect on the disease itself. So if you're giving pain meds to cancer patients, it will help them with their cancer pain, with their pain from the cancer, but it won't do anything to the cancer. Supportive effects, they support the integrity of body functions until other meds or treatments can become effective. So say you have a patient that comes in and they go into, they don't have a heart rate, they're going to treat them with the absence of the heart rate first. So they're going to give them some epi and stuff to get them going. And then they're going to look at the root cause and figure out a med to help with what, to treat the actual issue. Substitutive effects replace the body, they replace either body fluids or a chemical required by the body for improving function. So if you're looking at someone severely anemic, you'll give them some blood. Chemotherapy effects destroy disease-producing microorganisms or body cells, such as antibiotics and anti-neoplastic drugs. Restorative effects return the body to or maintain the body at optimal levels of health. Example, like, if a patient's not eating well, they're at risk for malnutrition and skin breakdown, maybe we'd give them protein supplements to help prevent that. So with pharmacodynamics effects of drugs, the secondary effects are unintended non-therapeutic effects of the med. Side effects are unintended, often predictable physiological effects that are usually well tolerated by patients. They occur at the usual prescribed dose and may be immediate, like dizziness, or delayed, like constipation. For hospitalized patients, you will often see side effects caused by analgesics, antibiotics, antipsychotics, and sedatives. The most common side effects are nausea, vomiting, diarrhea, dizziness, drowsiness, dry mouth, abdominal distension or distress, and constipation. Example, say I give my patient some morphine. I know this is a potent opioid and causes a histamine response. So I will expect to see the side effects to include some nausea, maybe a little itching, dizziness, drowsiness, and maybe a slight drop in their blood pressure. Adverse reactions are harmful, unintended, usually unpredicted reactions to a drug administered at the normal dose range. So they are more severe than side effects and often require discontinuation of the drug. The FDA defines severe adverse reactions as 1, they're life-threatening, 2, they require intervention to prevent permanent impairment or death, or 3, lead to congenital anomaly, disability, hospitalization, or death. Health professionals must document serious adverse reactions according to agency policy and report them to the FDA MedWatch program. Example, remember the IV morphine I gave to the patient instead of the typical side effects we saw in the example. Now the patient's complaining of mouth swelling and then drops their blood pressure to 50 to over 20 and stops breathing. Toxic reactions are dangerous, damaging effects to an organ or tissue. Toxicity may be caused by any of the following: overdosing, such as administering a dose that exceeds the prescribed amount, with examples including respiratory depression from excessive morphine and hypoglycemia from too much insulin. Accumulation of the drug in the tissues related to long-term use or incomplete metabolism or excretion, or abnormal sensitivity or allergic responses to the drug. Allergic reactions. Medications most frequently implicated in allergic reactions are antibiotics, biological agents, and diagnostic agents. The worst type of allergic RXN is called an anaphylactic RXN. The pathophysiology is that you have a huge histamine response that affects the entire body. One of the biggest worries is that the constriction of the bronchioles with edema in the larynx and pharynx. Because of the histamine response that occurs with anaphylaxis, you will also see a big drop in their blood pressure. If they don't receive immediate treatment, they will most likely die. Treatment is epinephrine, steroids, and antihistamines, and depending on severity, they may need to be intubated. Idiosyncratic reactions are unexpected, abnormal, or peculiar responses to medications. Idiosyncratic reactions may take the form of extreme sensitivity to the med, lack of response, or a paradoxical or opposite of the expected response, such as agitation in response to a sedative. You'll see that with Benadryl sometimes. The cumulative effect is the increased response to the repeated doses of a drug that occurs when the rate of administration is greater than the rate of metabolism and excretion. Your book gives the examples of opiates and barbiturates. Another great example is premature infants. They typically have lots of infections due to their immune systems and receive antibiotics. One that's frequently RX'd is gentamicin. Gentamicin is excreted through the kidneys, but these preemies have immature body systems, and guess what? They have a tendency to not be able to properly excrete gent and end up with toxic levels that can cause hearing damage, etc. Here's a table from your book kind of showing drug classes and example drugs that are frequently trigger allergic reactions. Just keep in mind, a patient who's allergic to one drug may also be allergic to other meds in the same class. For example, many patients who are allergic to penicillin are also allergic to cephalexin, a synthetic penicillin. Always ask the patient about allergies and their reactions to their meds. Remember to document allergies in the patient's medical records, on the care plan, and on the MAR. People with severe allergic reactions should wear a medical alert bracelet that identifies the person and the allergen, and should carry epinephrine for emergency injection. Up here you'll see kind of a list of why they tell patients not to drink grapefruit juice or eat grapefruits, because it interacts with so many medications. You'll know in long-term care facilities, grapefruit juice isn't even on the menu. So you have 3 types of drug interactions. You're antagonistic. One drug interferes with the action of another and decreases the resultant drug effect. That is, the combined effect is less than that of the drug when it was given alone. Synergistic. This is an additive effect. That is, the effect of both drugs together is greater than the individual effects. And then incompatibilities occur when multiple drugs are mixed together, causing a chemical deterioration of one or both drugs. The result is an incompatible solution that should not be administered. You can usually recognize an incompatibility when the mixed solution takes on a changed appearance. However, you should always consult a medication resources and compatibility charts before mixing meds anyway. Then after mixing, double check the medication for changes in appearance. Drug abuse or misuse. You should be able to differentiate between concepts that describe non-therapeutic use or effects of drugs. Tolerance is the decreasing response to repeated doses of a medication. The person then requires more of the drug to achieve the same desired effect. Example would be our cancer patients who need increasing doses of opioids because they have been on them for so long. Dependence is a person's reliance on or need for a drug. It leads to compulsive patterns of drug use wherein the user's lifestyle centers on procuring and taking the drug. Drug misuse is the nonspecific, indiscriminate, or improper use of drugs, including alcohol, over-the-counter meds, and prescription drugs. Drug abuse is the inappropriate intake of a substance by amount, type, or situation continuously or periodically. Unfortunately, nurses have a high level of abuse. The state boards of nursing have been doing a lot of research and creating programs to help peers identify abusers as well as get help for abusers. The federal agency that handles drug investigations is the U.S. Drug Enforcement Agency, or the DEA. Illicit drugs, are also known as street drugs, are drugs sold illegally. Many are prescription drugs like hydrocodone, sought for their mood-altering effects. Prescription drugs can be abused when taken for purposes other than medically intended. So medications aren't always available in the exact dose the patient needs, so you have to be proficient in calculating drug dosages to be sure your patients receive the correct amount of medication. The medication measurement systems, medications are usually prescribed and measured using the metric system. However, a few are still dispensed using the apothecary and household systems. You will sometimes need to make conversions from one measurement system to another. Metric system, it's the preferred system to measure drug dosages because it promotes accuracy by allowing for calculation of small drug dosages. A disadvantage of this system in the US is that many people outside the healthcare system are not familiar with it. The apothecary system, the British apothecary system of measurement, Roman or Arabic numerals, has been in use in the US since colonial times. Only a few medications like aspirin, example, are measured using this system because it's less convenient and less precise. Household system, although it's easier to teach a patient about home medications using this system, like when you're talking about teaspoons, ounces, or cups, nurses do not often use it because drug dosages are less precise and can lead to medication dosing errors. Special measurements like units and milliequivalents. Units like for insulin, a drug used by diabetics to help control blood sugar, is measured in units, with 100 international units, or U100, being the standard strength prep. In this strength, 1 ml of fluid medication contains 100 units of insulin. Heparin, an anticoagulant, and penicillin are also prescribed in units. But be aware that not all units are the same. For example, 1 ml of heparin does not contain 100 units of heparin. You must always read the container label to know the number of units per ml. Milliequivalents indicate the strength of the ion concentration in a drug. A milliequivalent is the number of grams of a solid contained in 1 ml of solution. Electrolytes such as potassium chloride are measured in milliequivalents. The key point, just note that units and milliequivalents cannot be directly converted to the apothecary, metric, or household system. So before administering any med, you must obtain a prescription from the licensed care provider with prescriptive authority and verify that it's complete, correct, and legible. For inpatients, prescriptions for medications are either entered into electronic health record like an EHR, for automated dispensing, or printed in the medical prescription section of the paper medical records. This was traditionally referred to as an order. For patients and for meds that will be filled by the patient instead of the agency or pharmacy, the prescription is written and given to the patient or family. This is a table from your book, and these are things you will always need to know for the rest of your life as a nurse. So these will be important for you to know what they mean and remember it. You'll see these kinds of things on your exams, and you'll also see them everywhere you work as a nurse. So make sure you know this. Nursing considerations with the medication order. So a written order, apply without a renewal date until the prescriber writes a prescription to alter or discontinue the medication or indicates on the original prescription a specific stop date. So a written order is an order to keep giving unless he said stop it on the order or until he stops it when he maybe sees the patient on his next round or something. An automatic stop date, this is a protocol that hospitals use for discontinuing medications after a certain length of time. Most narcotic prescriptions are in effect for only 7 days. If the medication is needed after the automatic stop date, the care provider must write another prescription. A stat order, this means that a single dose of medication is to be given immediately and only once. A single or one-time prescription indicates that the medication is to be given only once at a specified time, usually before surgery or diagnostic procedures. A standing prescription, these are officially accepted sets of prescriptions to be applied routinely by nurses for the care of patients under certain conditions or under certain circumstances, such as drug allergies or sensitivities. They establish guidelines for treating a particular disease or set of symptoms. A PRN prescription requires the nurse to determine in collaboration with the patient when the medication is to be given. The prescription specifies the condition for which the med is being given, the minimum time intervals between the doses. The medication cannot be given any more frequently than prescribed, even if symptoms persist. Pain medications, antiemetics, anti-nausea meds, and laxatives are usually given PRN. Communication of orders. Handwritten. The order is either handwritten on a prescription form or pre-printed standard medication orders and protocols. Orally, when you receive a verbal prescription, you as the RN will write the prescription and sign it with the provider's name, followed by your name and credentials. Medication names that sound the same can be confusing and leads to administering the wrong drug. So repeat the prescription to the provider and spell the medication name to ensure accuracy. When you get an order by telephone, usually this will be in response to a call you have placed to report a change in the patient's condition or the results of lab or other tests. The provider usually must co-sign verbal and telephone order prescriptions within 24 hours. That would be something for you to remember. So verbal and telephone orders, verbal orders or VOs are spoken to you often during a client emergency, and they should be made for critical change in the client's condition. A telephone order, or TO, received by phone and transcribed onto the provider order sheet have an increased risk of errors. Write the prescription only if you have heard it yourself. Make sure the verbal prescription makes sense with the client's status. Always repeat the prescription back to the provider to confirm accuracy. Spell unfamiliar names, pronounce digits of numbers separately. Directly transcribe the prescription on the chart. Date and time, text, to be followed by provider's name, your signature. Remember, providers must countersign VO or TOs within 24 hours. So testing your knowledge, the nurse is having difficulty deciphering the medication prescription written by a provider. What's the best strategy to clarify the information? Ask the patient what medication the provider prescribed. Call the pharmacist and ask him or her to read the prescription. Ask the nurse who knows the provider's handwriting to read the prescription. Or call the provider and ask him or her to clarify the prescription. So obviously you would ask the provider. You have to talk to the provider. Nobody else can tell you what those answers are. And if you look at all the other answers, all of them increase the risk of a medication error. So let's play a curveball. You've called the doc and he's less than helpful and tells you to do what was ordered and stop bothering him. What's your next move? So you should move up the chain of command with your concern, charge RN, house supervisor, unit manager, etc. Should this be an incident report? Yes. This should be an incident report because the physician incivility causes errors because nurses become afraid to clarify and collaborate. The patient will be the ultimate loser. I feel like statistically from when I first became a nurse, it seems to be better between nurses and doctors, but maybe not all the time, but maybe it will come someday. Who knows? The most common medication errors made by nurses are because of lack of knowledge. So maybe they don't, incorrect dosages, incorrect mixing, overly rapid infusing medications. If you sometimes with certain meds like vancomycin, if you give it too fast, it can cause what they call red band syndrome. So you know that you're giving the med too fast. Adverse effects, it's the most common factor contributing to the medication errors. Lack of information about the patient. Maybe you don't know what their allergies are. You don't know what other meds they're taking. That's why it's always important to be talking about medications. You don't know that their lab result came back and you weren't supposed to give a med until that lab result was reported to the doctor. Medical condition for which the medication is contraindicated is the second most frequent cause of errors. A drug is given by the wrong route. That could be one. And never ever administer a medication that you don't know, you don't understand what it's used for. So many easy ways to look up meds now. EMAR has a drug library, so right there on your MAR, the library, you can just pull it right up and it'll tell you what the med is for. And like we talked about before, the current drug reference book or the pharmacy. Faulty communication, maybe the written prescription is unclear, illegible, or transcribed incorrectly, resulting in administering the wrong dose or dosage. Confusion between drugs with similar names. The telephone prescription is taken incorrectly. Protocol is not understood or it is violated. A drug prescription is written on the wrong patient's chart. The wrong dosage is prescribed, like misplacing a 0 or a decimal point. Abbreviations are misunderstood. Poor or no documentation can result in error. Equipment errors. Wrong equipment is used to administer the drug, or equipment malfunctions, or it's not used properly, like a barcode scanner. Calculation and measurement errors. An error in calculating the dose is made so the patient receives the wrong dose. There's confusion in the unit of measurement. For example, a drug is prescribed based on kilograms and dispensed or administered based on pounds, or vice versa. Other things, medications improperly handled or stored. The patient's identity is not checked and the wrong patient receives the med. Lighting is inadequate. The nurse is fatigued, distracted, and interrupted. That could be true, right? And here is a big pet peeve of mine: the nurse leaving the medication on the bedside table and charting that it's been given. What could go wrong? I mean, what could go wrong, right? Well, the patient's not going to take it. Maybe they'll forget, and then it's going to look like he took it by your documentation. Then the wrong patient could get a hold of it, who might wander in their room. Someone might steal the med, depending on what the medication is. So we don't want to leave meds at bedside. There is a lot of technology to help prevent medication errors. Computerized prescriber order entry, or CPOE, helps prevent errors in transcription due to illegible handwritten prescriptions. Electronic prescribing systems are safer when combined with decision support tools that automatically alert prescribers to possible interactions, allergies, and other potential problems. Barcode medication administration, especially when combined with CPO, provides a highly effective system for identifying the right patient. It transfers data electronically, eliminating the error-prone paper transcription process. When used correctly, barcoding at the unit dose level prevents nurses from selecting an incorrect medication. You have smart pumps, where IV infusion technologies used at the point of care can help you avoid programming the wrong dose into the pump to ensure the correct dose is delivered. Once programmed, the delivery rate does not change. An alarm will sound or the pump will stop if a nurse attempts to program outside dosing limits or the flow is interrupted, like a blocked line. And automated dispensing cabinets minimize human handling of drugs in the pharmacy and are known to reduce medication errors when the built-in safety features are used. Patients are typically pretty smart about what they take, so use them as a resource. I always say, don't patronize your patient. If they ever say, oh, I don't usually take 2 of those pills in the morning, or my pill is usually a little rounder and maybe pink, instead of saying, well, it's a different pharmacy, or I know what you need because I'm the nurse and I'm the smartest person in the room, don't do things like that. If a patient ever said to me, and they have before, I don't usually take that in the morning, or whatever it is she said, I stop what I'm doing and I go relook at their meds. And that should be what you do. You stop what you're doing, say, let me go have a look at your MAR again. So that's what you need to do. But don't ever patronize your patient, because they know and they might save you from a pretty wicked med error. And that's always a good thing. So when we commit med errors, first assess the patient. As soon as we know that we've done it, we first assess the patient, including vital signs, and assess for negative effects. You should know the side effects of a med prior to administration, but if not, you should go look it up to see what you might be expecting. Next, notify the physician and the charge nurse. Follow any orders the physician prescribes related to the incident. Example, maybe the patient was transferred to the ICU, labs were ordered, etc. Document the medication in the MAR, making sure that you include the dose given. Example, I gave 10 milligram of IVP morphine instead of 1 milligram. So in the MAR, I will document that 10 milligram was given. Never ever do you document in the chart that a medication error was made. Instead, you do document the dose given, and you will also make a nursing note regarding calling the physician regarding the administration of morphine. Lastly, complete an incident report. This is where the mistake portion is documented and everything surrounding the mistake. This is also where you need to review your mistake and determine how and why it occurred and how to prevent such a mistake ever occurring again. So on your MAR, you'll have examples. There'll be an example on here that you'll see, and then we'll see an example in class. So you will document medications according to the times they are given, scheduled, unscheduled, continuous, PRN, stat, and so on. Drugs are listed to be given at certain times. Drug allergies are always noted on the MAR, whether paper or electronic. This makes them easily visible for caregivers who are prescribing and administering meds. Client refusal. If the client refuses the medication, note the refusal on the paper or electronic MAR. Your organization's policy will determine how this is recorded. Omitted medication or delayed administration. If the client is not available or is experiencing health changes that require an immediate intervention, it may be necessary to withhold a medication or delay its administration. Use the guidance on the paper MAR to indicate why the medication was withheld or given at a different time. Circle the scheduled time and fill in the symbol. You will also have to document the omission of delay in your nurse's notes. However, in the electronic MAR, often it is possible to reschedule administration times for a single dose or permanently going forward, or to document that a medication could not be given at the scheduled time and will be skipped. So when you're comparing to looking at everything you need to look at, you look at your MAR and compare your medication label to your MAR. But your MAR is what you're looking at. Your MAR has to be correct. So, when we compare the drug label to when drug dosing doing calculations, that's when we're really looking at the drug label to see what the label says. It might say reconstitute this with 1 mil of normal saline or sodium chloride or whatever it says. But when you're looking at medications and doing your 3 checks, you're comparing the meds in the drawer to the MAR. Okay? And don't make the mistake of, well, it's not on the MAR, but it's in the drawer. No. They have to match before we can get that med. Here's a MAR example in the computer here. So you have your medication administration there. Says your MAR. Here's your allergies, no known allergies. Sometimes, like here, it has this isolation procedure, what their weight is. I'm looking to see their diet's not on here. Some will have their diet on there. So if you see someone and it says they're on thin liquids or something like that, or thickened liquids, and you'll know to ask them what their swallowing's like or things like that. That's an example of a MAR you'll see. So before medicating patients, you would check the patient's allergy list prior to giving them any meds. You would measure their vital signs, assess whether the patient's general condition is appropriate for the med, evaluate your knowledge of the medication, and identify biological factors that affect drug metabolism. While administering meds, assess their mental status, their coordination, ability to self-administer the drug, swallowing for oral meds. After medicating patients, you assess effectiveness of the drug, side effects, signs of adverse reactions. When taking a medication history, explore the patient's allergy history, like medication and food allergies, what the reactions are and treatment required. You should always ask about the patient's history of illness, attitudes toward meds, learning skills, and whether the patient, if a woman, is pregnant or breastfeeding. Also, check relevant laboratory test results and obtain a list of current meds prescribed and over-the-counter and prescribing providers. Ask the patient about his ability or her ability to have prescriptions filled. Some patients are non-compliant because they just can't afford the meds. The physical exam helps you identify potential problems and the need for adapting medication administration procedures. Example, you are given a blood thinner to someone whose IV is using blood. So what would you do? Would you hold it? So you always do 3 checks before you give your medication. That's how your skill sheet checkoff will be, performing the 3 steps. So before you pour, you check the administration label against the medication administration record. So you want to look at the drug compared to the MAR. After you pour, you verify the label against the MAR. And then at the bedside, you'll check the medication again before giving. So nursing considerations, patients have the 6 rights plus other rights: right drug, right dose, right time, right route, right patient, right documentation. You'll need to know these by heart. And then other rights: right reason, right assessment, right to know, right evaluation, and right to refuse. The patient always does have the right to refuse the med, even if we think he should take it. He has the right to do that. So some pediatric considerations. You want to minimize distress for pediatric clients through atraumatic care, which involves providing interventions like creating safe spaces, avoiding separation from family members, and using play therapy. Allow young children to touch equipment, provide them with simple choices, and use techniques to mask the taste of medicine. Use age-appropriate dosing equipment and using a developmental approach when administering meds. Like allow school-age children to have input into medication administration decisions and explain the purpose of the med. Encourage adolescents to ask questions and provide them with detailed information about the medication. Sometimes with little kids, like 4 or 5, they wonder how long their appointment's going to take. If you talk to them developmentally, you could say, well, it won't take any longer than a cartoon, because really that's kind of their idea of time. So routes of medication administration, the most commonly used route is oral meds. So they can have tablets, capsules, enteric-coated, time-release, scored or unscored, liquids, buccal, sublingual, and enteral. Enteric coating prevents a tablet, if you remember, from dissolving in acid and makes it not dissolve until it hits the small intestine. These meds should never be crushed. Your time relief meds are meds that are given once or twice a day and released slowly over time. Those should not be crushed. Scored tablets are marked to be able to split. If they're scored, you can half them, but if they're not scored, you shouldn't. Liquid meds are frequently used for children and older adults. They usually come in multi-dose bottles, so you will need to pour individual doses into a disposable calibrated cup. When pouring, hold the bottle so the liquid does not run over the label where you can't read it, and hold the cup at eye level when measuring. Buccal and sublingual meds, although placed in the mouth, are intended for absorption in the mucous membranes rather than in the GI tract. Some soluble forms of medications and enzyme preps are administered by this route and are rapidly absorbed, some within seconds. Buccal medications are held in the cheek. Sublingual meds are held under the tongue. Enteral meds for patients who cannot swallow or have a feeding tube. You can give oral meds through a nasal gastric tube, a gastroscopy, or a jejunal tube. Remember, those tubes are long and narrow, so they clog off very quickly. Always flush after the medication with water and keep their head up about 30 degrees or more at least. There are always things to consider. There are some special situations: meds that discolor the teeth, mix such drugs with liquid, have the patient drink the solution through a straw, and drink a liberal amount of flavored liquid like juice or water afterward to dilute the medication. Contraindications to oral meds: do not give the drug to patients who are NPO. That means somebody that's taking nothing by mouth. Comatose, obviously. At risk for aspiration or experiencing nausea or vomiting. Obtain a prescription for an alternative route or request permission to give the medication with small sips of water. Patients who have difficulty swallowing meds, crush soluble meds and place them in liquids or in a small amount of applesauce or pudding. Remember that some forms, like time-release tabs, should not be crushed. Also, check your drug reference sources to be certain. So topical meds are applied directly to a body surface or cavity. Local and sometimes systemic effects occur. Lotions, creams, ointments, transdermal patches, eye and ear, nasal, vaginal, and rectal. So lotions, creams, and ointments to enhance absorption, cleanse with the skin with soap and water and pat dry before applying lotions, creams, and ointments. If you warm the medication in your gloved hand, it will be more comfortable for the patient and make the preparation easier to apply. Use a cotton swab, tongue blade, or gloved finger to apply corticosteroid creams and other topical medications so that the skin does not absorb them. Transdermal patches are designed to be absorbed through the skin. Transdermal meds are prepared as patches made of a special membrane. Patches allow constant controlled amounts of medications to be released over 24 hours or more, giving a prolonged systemic effect. Other routes of meds, you have the ophthalmic, which is ointments or solutions for the eyes. They're used for local effects, like to treat eye irritations, infections, glaucoma, or to lubricate the eye. Otic or ears, they're solutions that can be dropped into the ear to treat internal and external ear infections, to apply heat to the area and soften or remove earwax. Use solutions at room temperature because a solution that's too hot or too cold may cause vertigo, nausea, and pain. If the solution has been refrigerated, warm the solution by rubbing the bottle between your hands for a minute or two before use, especially for medication dispensed in a glass container. Remember, for adults, on the ear, you pull up and back, and on children, down and back. But kids under 3, you do down and back. Any kid above 3 and older, and then adults, you do up and back. Nasal, clients usually self-administer nasal drops and sprays. The most common nasal meds are used to shrink swollen mucous membranes and to loosen secretions and provide drainage for treatment of nasal cavity or sinus infections. Vaginal medications come in various forms like foams, jellies, liquids such as douches, creams, tablets, and suppositories. They may be used for contraception, to destroy bacteria in the vagina before gynecological surgery, to reduce vaginal dryness related to menopause, and to treat vaginal itching or infection, or to induce labor. Rectal suppositories and liquid installations or enemas are used to encourage bowel movements or to treat systemic complaints. Absorption is slow and erratic because of the fecal contents, local drug irritation, and uncertainty of drug retention in the rectum. Respiratory inhalations. So you have nebulization. It's the production of a fine spray, fog, powder, or mist from a liquid drug. The patient inhales the medication mixture by breathing deeply through the mouthpiece attached to the nebulizer. The airways and alveoli are highly vascularized and therefore absorb inhaled medications rapidly. Absorption via alveoli and blood supply. Atomizers. They disperse the medication in the form of large droplets. Aerosols suspend the droplets of medication in a gas, like oxygen. Then a metered dose inhaler is a type of nebulizer that delivers measured doses of a nebulized drug. On the metered dose inhalers, you rinse mouth before, shake before use, breathe out slowly, and then slowly inhale as you puff the inhaler. Hold breath for 10 seconds and breathe out. If it's a corticosteroid inhaler, rinse mouth after. Wipe clean mouthpiece. Do not soak the whole device to clean, as it can damage the valve mechanism. Parenteral med administration prep. So you, depending on the type of injection, sub-Q or IM, and the patient size, you will need to know different needle sizes. There's a table in your book for an overview. You'll get to practice injections in the lab. Yay, that's going to be fun. Vials and ampules. An ampule is a thin-walled, disposable glass container with a narrow neck that you must snap off to access the medication. To prevent injuries, use an ampule opener to snap the glass. Each ampule holds a single dose of a liquid medication, usually 1 to 10 ml, but some hold 50. Because glass fragments may be introduced into the medication, most agencies require you to use a filter needle or filter straw to draw up the medication. A vial is a single-use dose or multi-dose plastic or glass container with a rubber stopper that reseals the top after each needle introduction. A plastic or metal cap covers the rubber stopper to protect it until it is used. Because the vial is a closed system, you must inject air into it to withdraw the solution. Otherwise, a vacuum is created in the vial that makes withdrawal difficult. Reconstituting from powder, medications that are not stable in solution are dispensed as powders and vials. You must add a diluent or solvent to the powder to create a solution for injection. The diluent is usually sterile water or saline. However, each packaged vial includes the manufacturer's instructions for the amount and kind of solvent to add. For safety, use a plastic vial access cannula instead of a needle when possible. 2 medications in 1 syringe. You can mix 2 medications in the same syringe. 1, if they are compatible, and 2, if the total dose is within accepted limits, and obviously 3, if they are both to be given by the same route. This technique allows for efficient use of supplies and allows the patient to receive fewer injections. Medications are compatible if they can be mixed without affecting their constituents or actions. Package inserts and medication reference usually include compatibility information. You will be learning how to mix insulin in 1 syringe, and that will be part of your checkoff. So here's your ampules. So you see you break these off and you use, like she's got a gauze thing. Some of them come with like an ampule safety device, or you use a wash rag or something like that. Anything to prevent you from cutting yourself with this. And if you notice, she's going to break it away from her body when she breaks it off. And then your filter needles are only used to draw up medication. So you use that filter needle, you put it on your syringe, pull it up, and then you take the filter needle off and you change it to another syringe. You don't ever want to give a shot with the filter needle. So intradermal meds, they're given into the dermis, or the layer of the skin located beneath the skin surface. The intradermal route is commonly used for allergy testing or TB testing. Most nurses use the patient's non-dominant arm for TB screening and the dominant arm, chest, or upper back for all other tests. Here's your forearm, chest, and upper back. 0.1 mil is the max volume, your needle gauge 26 to 28, then your needle length 3/8 to 3/4 inch, and your angle is about 5 to 15 degrees. This just shows you a picture of the appropriate sites you can give an intradermal injection. And here, like, this almost looks like it's right in the anicube, but really it kind of be down here. Okay. Medications are given into the subcutaneous tissue, the layer of fat located below the dermis and above the muscle tissue for these shots. Abdomen, upper buttocks, lower back, and back of arms. Your max volume for this is 1 mil. Needle gauge 25 to 27, needle length 3/8 to 5/8, and angle of injection are 45 to 90 degrees. Just remember that absorption is slower than through the intramuscular route because subcutaneous tissue does not have a rich supply of blood as muscle. However, speed of absorption varies with the subcutaneous site selected. Sites on the abdomen and arms offer fastest absorption. Those on the thigh and upper buttocks are the slowest absorption. Medication is absorbed more evenly from the abdomen than from the thighs and buttocks because it is less affected by activity. This just shows you the appropriate size to give subcutaneous injections. Your intramuscular injections, so you can give those in 3 different sites: the deltoid, vastus lateralis, and your ventrogluteal. Your max volume for your deltoid, which is your arm, is 0.5 to 1 mil. The needle gauge is 22 to 25, the needle length 1 to 3, and angle of injection is 90 degrees. Vastus lateralis, 1 to 2 mil is your max volume in infants, children 12 and younger, and then 3 to 5 mils in adults. And then the needle gauge is 22 to 25, needle length 1 to 1/4 inches for infants and kids and 12 and younger, and then 1.5 to 3 inches for adults. Your angle of injection is 45 for inches and 90 degrees for adults. Then your ventrogluteal area, your max volume is 2.5 to 3 mil. Your needle gauge is 22 to 25. Your needle length is 1.5 to 3 inches, and then 90-degree angle of injection. This is your deltoid muscle on your shoulder. You see that what she's doing is your clavicle's up here, and she's going 2-finger breaths down. And then the top of this finger here creates your triangle, and this is where you would give the medicine. And we'll be doing practicing injections. I mean, you won't really give each other an injection, but kind of locating your site and stuff. Just remember the deltoid can't take a huge amount of volume. This is just a photo showing you how she's locating the ventrogluteal site for the shot on the ventrogluteal muscle. And here's the vastus lateralis muscle. This is an adult, kind of right here, on the far, part of the thigh there. See, that muscle looks good and strong there, doesn't it? This would be the vastus lateralis injection site on a little baby or a toddler. Okay. Sharp safety, preventing needle stick injuries, avoid recapping a dirty needle, and use sharps containers. We don't just throw them in the trash or anything like that. We don't stick them in a mattress. And you surely shouldn't recap like this. If you're in a pinch and you have to, you do the one hand recap if you have to do that. But the best practice is getting it in the sharps container. And some are safety syringes, so once you give the shot, it pulls the needle back, but not all the time. So just be real careful so you don't get a needle stick. So teaching medication self-administration. Know and understand what you're taking in order to take your drug safely and effectively. This is what we're telling patients. When you are prescribed a new medication, ask why you're taking it, how long should you take it, what side effects to expect, and whether you should take it with food or are there any special precautions. Keep a list of medications including doses and times taken. Take this list with you when you visit any healthcare provider or emergency department. You'll hear some physicians tell patients, hey, when you come to your appointment, bring your medications in the original bottles. Take the drug as it is prescribed in its prescribed dose for the entire length of time to receive its full effect. Older adults may forget to take their medications. A simple plan you can follow at home, such as a written schedule of a meds calendar, might help, especially if the drugs are taken other than at meal times and bedtime. If you can't see that well, ask a family member to write the schedule in large black letters, display it in a highly visible place. Some older adults may take the medication but forget that they did earlier, so you could use a divided pill container or a small glass filled with meds for each day's dosage during the day. So you could have one, that says morning with breakfast, one at lunch, one at dinner. When the container is empty, the patient will know. Hopefully that will trigger them to know that they've already taken that and they don't have to take the next one until later. Communicate with your prescriber. Notify your prescriber if you have side effects, adverse reactions, or questions. If you become pregnant, notify your primary care provider as soon as possible so your medications can be discontinued or adjusted. And think about safety. Be aware of your safety and the safety of others. Wear a medic alert bracelet or necklace if you're a diabetic. Take anticoagulants or have allergies to any meds. Do not take medications prescribed to others, and do not share your medications with others. If you take a variety of meds, post a list of them in a prominent place that is easy to see in the event of an emergency. Use child-proof caps if children have access to your medications. If no children are in the home, replace with simple closure caps for elderly patients who might have difficulty opening the containers. Families with young children visiting the home or older adults need to be alert to the risk of accidental ingestion of medication. Dispose of expired meds safely. Do not place them in the trash. Do not dispose of drinks in the sink or in toilets not environmentally sound because they can show up in the community water supply. Administer your drugs correctly. Read the label carefully on the bottle each time you take the medication so that you take the correct medication in the prescribed dose. Many tablets do look alike. To measure liquids, use kitchen measuring spoons rather than tableware, which can vary in volume. We need to make sure we do really exceptional teaching for patients with parenteral medications like insulin. This includes teaching regarding injection sites and rotation of injection sites, how to correctly draw up the insulin into the correct syringe, how to correctly administer the injection, and how to correctly dispose of the syringe and needle. If you have any difficulty opening containers and administering your meds because of pain or stiffness in the hands and fingers, ask family, friends, or family members or friends to help you. Ask the pharmacy and primary care provider not to put child-proof safety lids on containers for easier handling. Older adults are allowed to sign a release with their pharmacy to do this. Store your drug safely. Do not store a drug in a different container from the one it came in. The medication may lose its strength or you may take the wrong med. Store all your medications in a dry place out of sunlight and away from heat. If a medication requires a cold storage, be sure you return it to the refrigerator immediately after use. And maintain your supply. Your drugs need to be up to date and available when you need them. Monitor your prescription amounts and get refills before you run out. If you get meds by mail, be sure to order them in plenty of time. Check Check expiration dates and properly discard any outdated medications. Do not take expired meds. They may have lost their strength. Another thing I would add is make sure that we tell them to wear their glasses. You know, they need to be able to see. And personally, I'm allergic to ibuprofen, but there's ibuprofen in my house because my husband can take it. And of course, my youngest daughter can take it. So it's all kept in the same place. And I know I can't see well. So if I picked up a bottle, you know, I always have my glasses to make sure I'm not taking ibuprofen and I'm taking the Tylenol instead. But so that's good info there. So I know this was a long PowerPoint and I apologize. It was even longer for me because I had already recorded this whole PowerPoint and I exported it and I cannot get it to upload as a video in your modules. So I'm going to have to upload this recorded PowerPoint, which is probably going to mean you'll have to click each slide to hear the recording. So I apologize. So this sucks. So I apologize for that. Okay, so I want you to know that you need to study this, be alerted to this information, look through your book. Your volume 2 shows you every procedure for all these checkoffs you're going to do, and then we're going to go over your checkoff sheets, and you know, you're going to be fine. We're going to get through this, but I want you to do well on your exam. You know, we have 2 exams, then we have a few checkoffs, and then some kind of like peer checkoffs.